Thank you. Thank you, organizers, for the opportunity. So I'm going to discuss another Chinese trial. This was published as an original article in JNCI in 2022 January edition. This is from the University Hospital, China. The study title reads Randomized Clinical Trial of First-Line TKI Therapy with or without radiotherapy in synchronous oligometastatic EGFR mutated non-small cell lung cancer patients. So coming to the introduction, there are clinical trials that have suggested aggressive local therapy, especially radiotherapy, when applied to oligometastatic disease in non-small cell lung cancer patients. And these clinical trials have showed a variable amount of improvements in the PFS and OS. And some of these clinical trials have actually excluded the EGFR mutated non-small cell lung cancer patient. There is one randomized basket trial, but however, it has an underrepresentation of these mutation patients. This is the study title, SINDAS clinical trial. This is trying to address this knowledge gap of examining the applicability of simultaneous radiotherapy in patients who are taking first generation and second generation TKI therapy in oligometastatic non-small cell lung cancer patient with EGFR mutations. Very simple study design, open label, parallel group, phase 3 clinical trial. It included adult patients with the EGFR mutant non-small cell lung cancer, which is oligometastatic and treatment naive. These patients don't have brain metastasis and no exposure to prior radiotherapy. So coming to the important definition of oligometastatic disease, they have defined the oligometastatic disease as metastatic sites of less than 5 or less than 5. And if an organ is involved, no more than 2 discrete areas of metastatic disease were actually taken. All the patients were confirmed in the multidisciplinary review. And involved regional lymph nodes were taken as a primary tumor site, and involved non-regional lymph nodes are taken as a metastatic sites. So this is a very important slide. It has clinical implications for routine practice as well. Osimertinib was not allowed in the clinical trial because at the time of study design, it was not shown to have any improvement as per the available clinical trial data then when the study was designed. Again, RT was directed all the metastatic sites and as well as the tumor site, and it was completed within 2 weeks in 5 fractions. The dosing of the radiotherapy was quite variable from 25 to 40 gray. This is because of the variability of the tumor location and tumor size and metastatic disease sites. And no radiotherapy was allowed in the TKI therapy arm alone, except for those patients who require symptomatic relief or palliative radiation. And coming to the EGFR TKI, mostly it was first generation TKI of erlotinib and geftinib, and there was one more second generation TKI of ecotinib which was available in the China. And at the time of disease progression, more importantly, none of the study arms were actually allowed to take either osimertinib or immunotherapy because again, at the time of study design, the second line osimertinib or second line immunotherapy was not shown to have actually any survival benefit. So all the patients in this clinical trial have actually taken chemotherapy as a second line treatment. Coming to the endpoints, the primary endpoint was PFS, secondary endpoint is the OS, and the hypothesis is that when applied, radiotherapy improved the PFS of these patients at 6 months from 75% to 90%. So they calculated that they required 200 patients to achieve a power of 80% with a two-sided alpha of 0.05. And there was a pre-specified interim analysis of at 68% or 2/3 accrual was reached. So looking at this consort diagram from January 2016 to June 2019, nearly 630 odd patients were screened and about 136 patients were actually randomized for either arm. And the intention and the analysis was the intention treat analysis. So coming to the clinical pathological characteristics of the study population, the distribution of oligometastatic lesions were comparable in both groups. A majority of the metastatic disease was in the bone lesions, and expectedly these oligometastatic patients have very good performance status. Barely any patient was actually PS performance score of 2. And the most common EGFR abnormality was exon 19 deletion. Geftinib was the most common drug that was used, and the most common RT dosing was 30 gray and 25 gray. So coming to the results, at the time of study results, we can see that the local control and the tumor metastatic site control was achieved in nearly 90% of the patients in the RT arm and only 55.4% of the patients in the TKI therapy alone arm. And this actually has underperformed to the expectations of the investigators, where they expected that the patients would be having at least 75% disease control rate. And the median PFS was also improved in the RT group at 20.2 months versus 12.5 months, hazard ratio of 0.22. And OS was also similarly improved at 25.5 months in the RT group compared to 17.6 in the TKI therapy alone with a hazard ratio of 0.44. And the application of RT was independent predictor of both PFS and as well as overall survival. So these are the conclusions which I can draw. Basically, this trial collaborates basically the idea of utility of aggressive local therapy in oligometastatic disease, even in a very distinct tumor biology of EGFR mutated non-small cell lung cancer patients, which have quite varied treatment approaches and prognosis. Radiotherapy in this arm, in this study, was not standardized. A wide variation of doses were used, different plan technologies were used. However, the local control in the RT was quite satisfactory, and there was no evidence to suggest that higher doses of RT is going to improve survival. Again, this study is not going to reiterate the concept of application of RT to the oligoprogressive disease. This is a study in which RT was used simultaneously with the TKI therapy, and the application of RT simultaneously with osimertinib will again be into question because osimertinib has higher chance of pneumonitis and other complications related to the radiotherapy. So with that, I would like to conclude. Any questions? Thank you very much.